Good afternoon, members of the Commission, Chairman. I'm here today representing the Hampshire Hospital Association, where I'm an officer of the association and the Secretary-Treasurer, as well as Chair of the Advocacy Committee. I'm also the Senior Vice President of Financial Strategy and External Relations at LRG Healthcare, two hospitals in the Lakes Region, Lakes Regional Hospital, and Franklin Regional Hospital. I'm speaking today with strong support on behalf of all hospitals for Medicaid expansion. We see it as both a public health and economic imperative for our state. If you think about where we are as a state, we have implemented as a policy, or going to be implemented as a policy, Medicaid managed care. And what we're talking about there is fundamentally putting in place the infrastructure, the network to care for Medicaid beneficiaries. Leveraging access. Access is a fundamental building block, I think, to transforming the system. I know there have been concerns from an economic standpoint what expansion is going to cost the state, but I think if you really think about how healthcare is delivered, we've been focusing, if you think of a simple equation, price times Q, quality and quantity, we've been hitting P really hard, hitting price really hard, rates really hard. They've been hit as hard as they can be hit. It's now time to work on quality utilization, because that's what's really going to transform the system, not only for Medicaid beneficiaries, but also for the state itself, business, and individuals not covered by Medicaid, because fundamentally, in transforming our healthcare system and trying to work on the Q component, it takes a common platform to really leverage it. You think about how other sectors of our economy have been transformed. Take the financial industry as an example. And being able to standardize transactions led to great efficiencies. And I think in healthcare, our state is at precipice of a real great opportunity here to bring everybody on a common platform, access to the catalyst to transforming our system. Many hospitals are working already on these issues, but as has been noted by many of the credit agencies, we're working in an environment where we're working in mixed systems and centers, and being able to bring some rationalization that makes a lot of sense. Another issue that's come up is the issue of access. The Hospital Association did a survey just last week of 100 live practices associated with hospitals, and those 100 practices cover approximately 500,000 people in the state. And we confirm that hospitals are ready, willing, and able to accept the expanding population without it affecting the access of individuals who already have insurance. Other aspects of sustainability running the program. As I mentioned, Medicaid managed care is the first step, expansion the second. Working together with the State Department to solve long-term financing issues and delivery innovations is something that we're also prepared to work with the state on. A question that might come up is that there's been some interaction between the state over Medicaid in the past. I think, as I think the state's budget and the allocations represent, let's move forward, and I think hospitals are prepared to work with the state and community at large to do so. I know a limited amount of time here. Today, or yesterday afternoon, was a report in Forbes magazine that addressed our one report, which talked about hospitals being worse off under expansion versus not expanding. In other words, just relying on the ACA Act to provide coverage on exchange. The Lewin report, as folks talked about, is a very good report. There are, however, some limitations on the assumptions. One of the major assumptions, which I think affects how hospitals look at the analysis being made, so hurt hospitals, I think, to the tune of, in the article, we talked about $228 million, about $45 million over the 7-year period. The issue there is that, as any set of reports has to make some assumptions. One of the key assumptions is what is the premium that was going to be paid and from that respect, they assume that the current commercial premiums would be what would be the impact over people moving from what they call a product. And so if you think about premiums today in the commercial market being 200–250% of Medicare, in fact, how things are coming together, it's more like around 100% of Medicare. So when you're looking at that delta of the impact, it's probably at least half of what we expect. But I think the bigger issue is that in terms of transforming our system, that the aspect of getting things on a common platform. Finally, this is I got a 30-second signal here. DISH. There's been discussion at this commission about DISH going away. That's actually a fallacy. DISH allowance is going to be reduced. The amount of uncompensated care for hospitals has grown 40% in the last 5 years. The amount that's available for DISH, the state does not use its full allotment, and so we just want to make sure that's clear.
Good afternoon, Environment members of the Commission. My name is Rachel Crowe. I'm the Executive Director of Granite Healthcare Network. GHN is a collaborative of 5 large health systems in southern New Hampshire, formed in April 2011. It's a unique collaboration. Concord Hospital, LA Health System, LIG Healthcare, Southern New Hampshire Health System, and Wentworth Hospital have joined together to share their intellectual and clinical resources to provide better care for patients and better health for communities. I'm here with Dr. David Green, who's the Chief Medical Officer of Concord Hospital, practicing neurologist, and also intimately involved in our population health management program at Medicaid Healthcare Network. And we are here as clinicians in strong support of Medicaid expansion, and here's why. These patients that will be benefited by Medicaid expansion are not new consumers of care to our health systems. They are accessing care already, not necessarily in the most cost-effective manner. By opening up this expanded Medicaid program to these patients, they will be able to access the important and vital preventive and wraparound services in a much more effective setting, such as rural health clinics, community health centers, much more so than the expensive emergency departments. So I'm going to now turn over to Dr. Green, who's going to talk about how GHN is working together to integrate those patients into our community health systems.
Thank you very much. It's a privilege to address you. I am representing Granite Healthcare Network Hospitals. What I'd like to share with the Commission is our shared commitment to improving the health of the populations that we serve. And what we have done as 5 organizations is to try to transform how we deliver primary care. So we are all endeavoring to NCQA certified level 3 medical homes, which will give a great focus on need-based care. So the traditional model that you may be used to of thinking where will I go and see my doctor, and everything is doctor-centric will be different. It will be much more need-based care. We have a shared commitment to better care management, not just for Medicaid patients, but for all the patients that we serve. And we already have initiatives in a collaborative fashion around asthma, low back pain, depression, and others. Capacity-wise, because of this transformation of the model of care we have to more need-based care, it will be, I think, relatively easy to absorb an influx of patients over the next year to 2 years. And as Rachel mentioned, we already provide their care anyways. And we will be endeavoring to maximize in the scope of their practice what nurses and MAs can do. And I do think this will make for better, more cost-effective care. And I would like to share with you just one example of a patient I saw about a week ago. This is a 21-year-old gentleman who had 3 days of symptoms of a urinary tract infection, which he put off because it was employee and he had no insurance coverage. He finally presented to our emergency room and probably walked away with a charge of around $2,000 to $2,500. The ER referred him to me as a urologist, and so because he came from the ER, we put him on the top of the list to lay other people who've been waiting to come see us. His combined charge for that care was probably around $3,300 to $3,800. If he had had Medicaid coverage and was in Medicaid managed care, that individual would have been able to call up his primary care provider. A nurse probably would have triaged that call. At worst, the patient would have been asked to come in. A level 2 visit for a nurse practitioner might have cost $150, but it would have avoided clogging up the ED. He wouldn't have gone to an expensive specialist and had a ripple effect of delaying access to the specialist. And his care would have been significantly better. So I think collectively, my colleagues and I and Granite Healthcare Network feel that expanding Medicaid would improve continuity, improve quality, and I think across the board benefit all of us. And I thank you for your attention.
Thank you, Commissioners, and thank you, Senator Gilmore, for providing an important message for the world. My name is Fred Kelsey. I'm an internist. I've been in employment since 1980. I'm the medical director of the Medicaid Health Center, which is an NCQA advanced medical home, and also an NFQA civil life. And also, I'm the medical director of the World Country Shared Savings Center.
Closer.
Feel like I'm talking. I've been asked to, first of all, present primarily the primary care in New Hampshire and comment on both capacity and how they can exchange to the members. In a nutshell, capacity is we have a capacity. Recently, the Medical Society had a poll of all licensed primary care physicians, not our partner PAs, just physicians. We have capacity for 2 million people. I believe the population is about 1.3. So even without our partners, interns and PAs are a key piece of our primary care team. We have capacity. Data at Medicaid, years back, our own country care partners showed that since about 2008 when the crisis occurred, we're running at about 75 to 80% capacity. So even if everyone showed up at doorsteps on day 1, we can handle that capacity without jeopardizing people keeping their home. Past fiscal year, the state along gateway provided $418,000 worth of uncompensated care. And we look back at that patient population, about half will be covered under that expansion. Therefore, actually added $200,000 of funds which we use to expansion later as needed. What I'd like to do right now is just get 2 patient vignettes to kind of demonstrate how this expansion makes a difference. First is a 50-year-old male we saw follow up in recent hospitalization with onset diabetes and heart failure. He worked as a self-employed maintenance worker, trucker. Last time he saw doctors and was discharged probably from the Army, felt fine, and now he shows up for follow-up. He now has several chronic conditions. He has $600 a month in prescriptions to fill. He's lost his commercial driver's license due to diabetes. His physical capacity is reduced. These are all real threats to disability and actually mobility. The other patient is a 20-year-old woman with marginal income due to spot seasonal work. No regular medical care except the year 7 years ago for auto accident. Usual history, challenging childhood, spotty academic career. And her stated reason was going for a checkup. When she gets to the office and sits down, the real reason is she wants to deal with her narcotic addiction. Now, this is a lady who, had kept that a secret from her friends and family. Now, what's the common theme of both these vignettes? And the theme is failure. The system failed both those patients. And dedicated clinicians, and how many people I want to look at mid-stage, don't deal with failure very well at all. We succeed through a process that depends on reading every time, training a good outcome is the only outcome that is acceptable. The clinicians are expected by the patient community to have solutions that are needed. We're pretty much addicted to success in the time of our COVID pregnancy. The 50-year-olds in for us exam room for me. Now is a decreased lifespan, loss of financial security independence, further than wants to reverse these losses. I feel grief, sadness, frustration, because I know that very probably if we had seen these risk factors early, this all would have been better. The 20-year-old case is just basically frustrating. Here we have someone who struggled alone with a life-threatening disease, brought herself to the denial phase, the shame of revealing her secret addiction, and assuming financial risk of seeking treatment. This is a big thing. You know, as a clinician, that the window of opportunity to successfully treat this patient is now. There is no detox available, and she came in to see what that was. Your opportunity is dead. She leaves, fails. Now, how do these vignettes relate to primary care? I left primary care. I walked away from practice that I started in nurture for 20 years. And I left it because I was frustrated with the system that made it difficult for me to take care of patients. Not the patients, but the system. Fortunately, I found a way to kind of get around that, and I'm very happy where I am now. But that feeling of frustration is not, that's not alone. I think every physician in the state field, in particular, primary care. So my message to you is to lead the expansion of the way to support the following issues. One is workforce morale. Clinicians want and need to help their patients. Frustration and sense of failure occurs from the team. Retention. A career in primary care, or for any care for that matter, needs to be fulfilling. Before clinicians and leaders, I did. Recruitment. We want New Hampshire to have the tools to care for our patients. We are competing across the United States for good clinicians. We want New Hampshire to be known as a state that can provide those tools. And finally, efficiency. Even with a medical home team-based care, which we have in the state, we need our capacity to care for the unavoidable, non-preventable. My last comment is just opportunity. I've been privileged to serve on the Workforce Commission, also the New Hampshire Multi-State Medical Home Project, the New Hampshire ACO Project. This has given me an opportunity to see the incredible talent, energy, and commitment our state has, and they're dedicated to providing quality care for our citizens. Irrespective of one's political philosophy, we believe in the last one of the government what to do. Accepting expansion money provides unprecedented opportunity to make a real change in healthcare delivery for our citizens, and we have the right to get it done. Medicaid expansion will restore our opportunity, but that provides a positive way. Primary care, patient comes first, we're asking you to notice on that.
Good afternoon, Mr. Chairman and members of the committee. Thank you for the privilege to address this commission. My name is Mary Wilson. I'm a family nurse practitioner and a certified nurse midwife. I've practiced in New Hampshire for the last 30 years, mostly in Carroll County. I'm a member of the medical staff of the Infusion General Healthcare. The New Hampshire Nurse Practitioner Association fully supports Medicaid expansion to those up to 130% poverty. Nurse practitioners have a long history of providing primary care and immediate services to low-income individuals and families. It was not too long ago low-income children and their mothers were provided with high-quality preventative care services by nurse practitioners in church basements and visiting nurse offices. As insurance coverage and access to the private health care market was beyond means, we would arrive 30 minutes prior to the clinic opening. We would set up the exam tables, we would balance the scales, we would prepare immunizations, these same patients, children up to the age of 19, have access to primary care with CHIP. For low-income working adults, the picture is much bleaker. Nurse practitioners across the state see many working poor who, because of their low wage, are unable to afford health insurance. If you close your eyes for a moment, you can see the faces of many of those who we now call working poor. The middle-aged home health aide who cares for your mother, the mother of two who works as a waitress whose husband is out of work and poured your coffee last weekend, and the young man who changed your oil and just had his first child. Without health insurance, poor adults often postpone needed care and seek access to the emergency room. Bonnie is a 62-year-old woman who has not had any health care for the last 20 years. She presented to the local emergency room 2 months ago with severe hypertension, congestive heart failure, and a hemoglobin A1C of 11, which indicates that she has chronic diabetes that is not well controlled. She spent 3 days in the ICU and 2 more days in the hospital. I have seen her twice a week for the last 6 weeks, and she's much better. But this is the most expensive way to obtain medical care. Bonnie is not alone in receiving care in the most expensive way in our current system. Mike is 25 and works as a landscaper. He has asthma, but struggles to buy a steroid inhaler that costs over $100 a month. When work is slow or it rains for 5 days, he doesn't have $100 for his medication. And if he gets a cold, he ends up in the emergency room needing treatment. Again, this is the most expensive way to manage his asthma. Why does the Nurse Practitioner Association of New Hampshire support Medicaid expansion? The evidence is clear that Medicaid will reduce the use of expensive, non-urgent care. In studies that were done by the Summers in 2012, they found the utilization of emergency services for emergent and non-urgent care were similar for those with private insurance and Medicaid. This translates into less waiting time for everyone with a real emergency. Medicaid expansion also will decrease rates of delayed care because of cost. There have been concerns raised about the access and supply of nurse practitioners available to meet the expanded increase in care utilization. Approximately 1,500 advanced practice registered nurses working in New Hampshire, many of them serving as primary care providers. New Hampshire is proud to have graduated over 500 nurse practitioners representing family, adult, and psychiatric specialties from both Riviera University and the University of New Hampshire. Over 60 nurse practitioners are expected to graduate this year alone. These local programs report an overwhelming majority of their graduates continue to work in New Hampshire. As an example, an impressive number of nurse practitioners who graduated from New Hampshire programs currently work in Berlin, Littleton, Durham, and Lancaster. Many of these nurse practitioners began their career in families and towns where they now provide primary care. For New Hampshire, for nurse practitioners across New Hampshire, the 2011 Kaiser Commission on Medicaid and Uninsured Report provides a picture of New Hampshire that mirrors the nation. Nationally, the majority of nurse practitioners practice in primary care. Specifically, Dr. Deb Sampson and APRN from New Hampshire reported that 29% of primary care providers in New Hampshire are nurse practitioners. A recent analysis by ARPA in 2012 of the Atlantic Corporation predicts that nationally the number of nurse practitioners is projected to nearly double by 2025. They have concluded that the role of the nurse practitioner may be one important solution to improving access to care. Importantly, they found that none of the studies in the National Government Association's literature review raised concerns over the quality of care offered by nurse practitioners, and nurse practitioners provide care, nurse practitioner provided care is comparable to physician providing care on important process and outcome measures. In closing, I want to reiterate the Nurse Practitioner Association's support for Medicaid expansion, including access to care for low-income adults, will improve health and contribute to healthier individuals, families, and communities. It is a wise economic investment in the future of the Hampshire. Thank you.
Mr. Chairman and members of the committee, thank you for the opportunity to come before you today to give you the lens from the provider and patient perspective. For the record, my name is Stephanie. I'm the President and CEO of ICD Primary Care Association, and the purpose of my testimony is threefold. One, to let you know who ICD Community Health Centers are, to present our unequivocal support for Medicaid expansion, and to provide information about the workforce in New Hampshire and community health centers, all in 6 minutes. So VICE is a not-for-profit, nonpartisan two-state organization in New Hampshire representing 17 community health centers. We promote and advocate for access to everyone regardless of their ability to pay. The health centers are local non-for-profit charitable organizations that provide cost-effective, high-quality, team-based, comprehensive primary and preventive care to everyone regardless of ability to pay, serving over 122,000 patients, of which 35,000 are uninsured. They provide oral and dental care, behavioral health, substance abuse counseling, and pharmacy services. They see people regardless of ability to pay based on a sliding fee discount, and we estimate that 67% of the community health centers patients live at 138% of poverty or below, which is the threshold of Medicaid expansion. Community health centers have decades of experience, and together, ICD and health centers unequivocally support Medicaid expansion to increase New Hampshire's access not only to primary and preventive care, but to insurance coverage that opens the door to the broader healthcare system. And I wanted to talk a little bit more about that broader healthcare system. So many of the uninsured need treatment by specialists, and those patients that go to the community health center, if the community health center has a relationship with a specialist, they receive a sliding fee discount for that specialty care. If the health center doesn't have a relationship with them, then the patient has to pay out-of-pocket expenses, and those out-of-pocket expenses are most unaffordable. As a matter of fact, negotiating for specialty care from a primary care perspective for the uninsured is inefficient and unnecessary and would not be necessary in Medicaid expansion. I wanted to provide testimony very briefly from 3 patients at a health center. And the reason that I want to let you know about the patients is this old adage of, but for the grace of God, go I, that any one of us could be on Medicaid at some point in our life. One patient is a 30-year-old who was involved in a serious and very traumatic car accident. She's a part-time nurse aide. She has diabetes, and now she has PTSD. She has difficult working because of the accident, and she needs more intensive eye care because of her diabetes. She has very little income, and she can't afford specialty care. Another is a 50-year-old male with 3 children. He's a self-employed music instructor, and 5 years ago, when his children needed care, and he and his wife expended all of their income, of their savings, on his care. And this drained them, and now he, the father, has uncontrolled diabetes and hypertension, and he also needs specialty care. A 31-year-old who works at a sub shop, the patient has mood-related disorders, and he went to the health center for anxiety and depression, but found the condition was much more complex, and after 5 days in the hospital, needed a medication that actually needed a blood draw on a weekly basis at $100 for each blood draw. And so therefore, he's not taking his medication, and he's not working. And every uninsured has a unique story. All of these patients would have benefited from Medicaid exchange for not only primary and preventive, but for specialty and hospital care as well. Medicaid can change the way people live. And over time, the subsidies that are given to any of the providers can actually be reduced if all of the providers were to get coverage under the Medicaid expansion. And the Medicaid expansion would provide greater health and economic stability, not only to our citizens, but to the providers who take care of them. I know that the Commission is interested in the health center workforce capacity. The New Hampshire Community Health Centers have the capacity to see additionally newly insured patients. The community health centers have open access schedules where patients can be seen on the same day or evening appointments, and the current wait time for current patients is same day to 1 to 2 days, and the wait time for new patients would average 2 weeks with the lowest being 1 day. As the uninsured patients become covered in either the marketplace or in Medicaid expansion, the patients will be continued to be served at the health centers, and those patients that are uninsured then will be covered. The investment in primary preventive care will eventually and over time ease the uncompensated care burden carried by the state and commercial carriers. Regarding timing, what we know from other states is there is a need for new services when one becomes insured, either through lack of regular care or affordability. However, not every person is expected to benefit from the Medicaid exchange will come to a health center or health care provider on day one. These patients will not magically appear. Most are already in the system. We already see many of these patients. Medicaid expansion is not an inconvenience for us. This is what we do. These are who we serve. And this is our expertise and our core business. There was some mention earlier about the sort of larger healthcare delivery system changes that are happening. And I wanted to make sure that I made remarks about this because healthcare reform is changing the financing and the delivery of how we get our care. And so this idea of having a face-to-face with only a doctor or nurse practitioner is changing. This is really the hallmark of how community health centers provide care through a team-based, multidisciplinary approach. And in the future, all providers are going to need to move to this care. These changes will really impact our workforce. It's a team-based approach with nurse practitioners, physicians, nurse educators, behavioral health specialists, licensed social workers, care managers, care coordinators. So if you combine the community health center cost-effective model of care with the workforce team-based approach, the community health center is going to be an enormous pillar of support for the Medicaid expansion. With regard to workforce development and infrastructure, Bi-State houses the state's only not-for-profit clinician recruitment center. We assist over 40 organizations. We have placed over 300 clinicians with about 50% retention into our state. The recruitment center's core business is to outreach to national audiences of clinicians in training and practice, to recruit and retain providers, and establish and maintain relationships with dental schools, residencies, and medical schools as well. In New Hampshire, we have the Dartmouth Family Practice Residency Program, we have the nurse practitioner training programs at UNH and Riviera, we have PA training programs, and our state has tools to help us retain providers. We have a loan repayment program, we have a Conrad Brady J1 visa program, we have a National Health Service Corps, and we have a new clinician placement program. So in closing, Bi-State and the health centers fully support, without reservation, the Medicaid expansion. The community health centers have the capacity and want their services for the Medicaid expansion. We will continue to use our cost-effective and team-based model. New Hampshire has the experience and the ability to train and recruit professionals. So if you are asking providers what they want, they are strongly in favor of Medicaid expansion. And I look forward to working with you and answering any of your questions.
My name is Sloan Griffin, and I'm the President and CEO of Essential Behavioral Health in London. I'm here today representing 10 community mental health centers in New Hampshire, which comprise the New Hampshire Community Behavioral Health Association. And I will be submitting a position paper for the association today. It will also be posted on our website if anybody else is interested in reading it at www.nhcha.org. Our association supports Medicaid expansion for 3 reasons. 1, it will help improve access to mental health care and substance abuse treatment. 2, it will help address the issues of parity of those that can and cannot receive care. And 3, it will help sustain New Hampshire's community-based mental health delivery system. You've most likely seen on the news and on television that we have a lot of adults and children that are waiting in the emergency rooms of our local hospitals. So as you know, many of our uninsured are seeking care at the most expensive level of care in the state. They're entering the system when their condition has reached crisis, because they haven't been provided any kind of preventive care in the community. On one day this month, 8 of 17 beds in one of the community hospitals was taken up by a person requiring behavioral health services. Statewide, there were 47 people one day this month in the ERs waiting for psychiatric care. That means that other patients with medical emergencies, cardiac problems, strokes, and anybody at serious risk was waiting for a bed. Psychiatric care in the ER is focused on the immediate crisis, to stabilize the individual, not to address the underlying or longer-term issues. So in fact, the folks in the emergency rooms that are waiting for psychiatric care, in fact, are not receiving psychiatric care, it's just being postponed. But the legislature has put much needed funding into our 10-year mental health plan budget this year, and we thank you all for that. More beds is not the only solution. Because continuing to deny coverage to one segment of our population based solely on their ability to pay will not allow them to get basic services that they require. Mental illness can be a disorder that begins long before it's ever diagnosed. So by the time a person with a severe form of mental illness has reached a critical situation, accessing services can be a major challenge. Untreated behavioral health problems significantly reduces a person's level of functioning, and the consequences are often seen in job failures, housing issues, social problems, physical health illnesses. Serious financial, social, and legal problems are often related to untreated behavioral health conditions. Simply put, people with health insurance coverage get access to preventive health care and follow-up services, not according to people who can't pay. And health insurance means that people get their care delivered in a more timely and appropriate way. The New Hampshire Community Behavioral Health Association believes there is something basically wrong with limiting access to health care based on coverage or based on income. There has been discussion about capacity and questions about whether or not the system can handle the Medicaid expansion population. The answer is that community mental health centers are already seeing many of these uninsured individuals who just aren't getting paid. The other point to keep in mind is that not all 58,000 newly eligible Medicaid expansion clients will show up on the first day. So while workforce is an issue for us, and it was one of the issues not addressed, actually, in this year's 10-year plan budget, we are confident that we can handle the new population. I want to share a brief story about a person in my area who really would benefit from the Medicaid expansion. We have a 42-year-old woman who we are encouraging, we know of in the community, and we are encouraging her to access our services. Her husband was recently killed in a tragic accident, so she's uninsured. She has 2 small children. She's a stay-at-home mom. And right now she's suffering from clinical depression. She barely gets out of bed. She's not eating very well. She's not sleeping. She's embarrassed to access services because she has no ability to pay for them. We're trying to encourage her to learn that we will provide those services anyway. We do have citizens that it matters whether or not they're able to pay for services. So we continue to encourage her to access our services and hopefully we can treat her. She would greatly benefit from Medicaid expansion because she would feel at least as though she's able to pay for some services. Finally, I want to add that while it's not perfect, the Affordable Care Act is going to help us move away from an illness-based system toward a health-based system in this country. This is going to be better for our health and for our economy in the long term. Preventive care and dealing with people who want to be healthy versus people who are waiting to access care who are ill is a much better approach to our citizens' health care. I strongly urge you to recommend that the state proceed with Medicaid expansion. Thank you for your consideration.
Thank you very much, Mr. Miller.
Mr. Chair and members of the Commission, thank you so much for the opportunity to speak to all of you as representatives of substance use disorder treatment providers in New Hampshire. My name is Stephanie Elaine Samar. I'm a New Hampshire licensed social worker and Vice President of Families in Transition, a nonprofit that provides housing and specialty services like the Family Willows, a substance use treatment center for pregnant and parenting women. I also sit on the treatment provider seat on the Governor's Commission Commission on Alcohol and Drug Abuse Prevention, Intervention, and Treatment, and co-chair the Treatment Task Force for that commission. And finally, Families in Transition is member of the New Hampshire Alcohol and Other Drug Service Providers Association. Medicaid expansion is an extraordinary opportunity for increasing access to treatment for thousands of New Hampshire citizens. As required, substance use disorders will have parity with medical services. That's important because today, New Hampshire Medicaid is not currently reimbursed for substance use disorders or the providers that give them. Currently in New Hampshire, approximately 113,000 residents need treatment for alcohol and other drug disorders, but only 5,500 are able to access needed treatment through state-contracted facilities. New Hampshire annually ranks in the top 5 of the 50 states in drug and alcohol abuse and dependence. While we rank in the top 5, it ranks at the lowest end in terms of access to treatment. New Hampshire's 49th of the 50th state for people in need of treatment for substance use disorders but not able to access it. 8,000 New Hampshire citizens with substance use disorders would be eligible for substance use disorder treatment through expansion of Medicaid. Those citizens include, but are certainly not limited to, low-income working parents, homeless people, individuals on probation, parole, uninsured young adults, and the list goes on. Substance use problems translate into heavy burdens on the state and local systems, places that they really shouldn't be treated. Jails, prisons, emergency rooms, state and local law enforcement, child abuse, neglect, domestic violence, and reduced workforce productivity for all of the businesses across the state. Currently, those who would benefit from Medicaid expansion either do not have access at all for any services or are being provided treatment through those state-contracted facilities with very limited resources or have uncompensated care. As far as capacity goes, providers have been preparing for that for the past 2 years. The New Hampshire Alcohol and Other Drug Service Providers Association reports that the vast majority of substance use services that are not reimbursable by Medicaid today. However, the majority of providers report that they're currently or are in process of becoming Medicaid eligible to meet that need. With this additional reliable revenue, substance use treatment providers will be able to meet the increased demand by hiring additional staff and expanding the array of services offered. How we know Medicaid expansion can help those we see every day in need of treatment but without access can be recognized through the eyes of a gentleman that lived in our housing program at Families in Transition about a year ago. He had a history of alcohol dependence, but was able to maintain employment just the same. And unfortunately, as his addiction began to spiral out of control, he ended up having difficulty maintaining his employment and ended up with Families in Transition. With staff intervention, as we saw the illness getting worse, he finally agreed to go to treatment. It was an opportunity that we needed to take quickly. When we discovered and he discovered that there was a 6 to 8 week wait for a state-contracted bed, he began to lose hope, and he began to spiral even more out of control. Despite every effort, he decided to leave Families in Transition. Unfortunately, Families in Transition found out a month later that he had died of alcohol dependence. What if he had had treatment when he was motivated for recovery? What if he had had access right then and there when he said he needed it? Would he have been homeless again? Would he have died? I think not. And then finally, as I asked our Family Willows program manager for our substance use treatment program for stories or examples, her response was pretty illuminating when she said, "It happens every day, Stephanie. What story do you want me to pick?" Medicaid expansion can help make this matter-of-fact response from a provider a thing of the past. Thank you.
Thank you very much.
Thank you, Mr. Chairman, members of the Commission. I'm pleased to be able to have an opportunity to say some brief comments. For the record, I also submitted a letter from Lisa Gartley, Anthony Russell Blue Shields, plan president. I am standing in for She's unable to be here. I'm the director of government relations. And the letter will reflect that we indeed support Medicaid expansion. And I've been listening to the comments, and I'm forward to the comments after this section of the program. And it occurs to me, you'll see it in Lisa Burton's letter, that the whole discussion around Medicaid expansion is really driven by the challenge we face. If you went back to even 3 or 4 years ago, I think the projections are that we have about 50 million people in the United States that have no access to insurance. And unintended, that 50 million by 2020 would be 60 million. And as I was sitting here, I was reflecting, I don't know whether Steve Norton is in the audience, but when he first came to New Hampshire quite a few years ago, he came, I think, working for a consultant, and it was before literally the turn of the century. He was doing a survey on the uninsured in New Hampshire. And I remember we had discussions about how he was doing the survey. Was he using telephone? Would people without insurance have access to a telephone? All the questions around whether the survey would be about finding the uninsured. So back before 2000, it would have probably been the mid-90s, we had fewer than 100,000 uninsured according to that survey. And today, I looked at the literature, and I've been at the commission hearings, and it seems to me we're close to 170,000 uninsured. So if you go back to Washington during 2009 and 10, and you start thinking about what was driving the discussion down there, which sort of correct guidelines. And suddenly, on March 23rd, in 2010, we have the Affordable Care Act. It was our job to mail through 3,000 pages. But let me tell you, there had been a lot of discussion down there about how to address the dislocations in the system. Now, Anthem has been in New Hampshire as Anthem since 1999. And prior to that, it was Blue Cross and Blue Shield, the old nonprofit. So we are deeply embedded in the healthcare finance and delivery system. And we see a lot from our point of view. And we try in surveying the members we have to take their perspectives in hand. And we know that the biggest reason people are uninsured is they simply can't afford insurance. So go back to Washington. And they're starting to talk about something called shared responsibility. That term is sort of evaporated, except it's now associated with possible tax upon large employers. But it was more than that back in 2009 and 10. It was about we're all in the system together. In a wealthy westernized nation, we should probably have a better system. And what we're doing now is we're sort of putting up with a lot of dislocation and distortion because we don't have a system, and I'm going to steal Henry's term, that is rational. And so they said at Washington, how can we make it more rational? And I don't care where you sit, you may disagree or agree with what they did, or you may in hindsight see that they could have done this better or that differently, or maybe they shouldn't have done this. But the reality is they did a lot in concept. And so that it's like a three-legged stool. So they wanted to retain employer-based insurance. They wanted to slice the uninsured market into 2 cohorts. Those that simply didn't have enough income, even with the subsidy that they would get in the exchange, to afford insurance. And so the line is wrong. Some say, well, why isn't it 100? Because the subsidies go from 1 to 4. Well, I don't know the answer to that. But the reality is there's an opportunity here to rationalize the system, as Henry Littman would say, and expand Medicaid. And I don't know, I read the article that was circulated on the internet from Forbes today, and they had statistics in there about if you didn't expand Medicaid, if you expanded Medicaid, it would only produce 22,300 more lives insured than if you did expand it. Now, maybe it's the reverse. I got very confused. But the reality was, there are uninsured people in New Hampshire who clearly are Medicaid eligible, and you're going to hear from them after this session. And they're going to tell you what it's like to go and not have insurance and worry who's going to pay the bill. And so, Anthem in the system feels that we should explore very carefully the option of expanding Medicaid. And maybe the New Hampshire way of doing it would be a hybrid or something creative, and maybe there's tolerance for that, but to just let this opportunity go by the board. And when you say opportunity, everybody talks about Medicaid expansion as sort of a new idea. Well, I went back, and I've been around quite a long while. When I went back in some of my files, I found that Medicaid expansion has been talked about since the mid-90s. And the reason it didn't happen very aggressively is because the incentive from the federal government to pick up 100% of the cost for the first couple of years and 90-10 for the rest wasn't there. So we're at the cusp of an important decision. We feel at Anthem that we should do something to reduce this dislocation in the system and create a system that's fair. Thank you.
Thank you very much.